and more relevant. So the cervix is a very, very important part that we are not measuring properly. And unfortunately, if you don't measure, or if you don't image something properly, it has the potential to affect every obstetric patient. So the cervical measurement, we look at the risk of preterm delivery. Unfortunately, there is no decision on the best approach to the cervical surveillance during pregnancy. Should every woman have a transvaginal scan, or can that be restricted to those women that have a short cervix on the initial transabdominal study? There are advantages and disadvantages with both techniques. When we look at the transabdominal, every patient accepts that. It's very convenient. And most importantly, we don't need to do high-level disinfection of our transducer. The disadvantages is that the image quality is dependent on the maternal size. In Australia, we have big women, about 150 kilos. That is routine. And also the amount of fluid in the bladder. The transvaginal study, it is much clearer, especially when we're looking for the internal and the external os, and also the relationship of the placenta to the cervix. The disadvantages is that it takes longer, and the probe needs to be cleaned properly at the end of it. And some patients don't like having a transvaginal scan. When we look at evidence-based practice, when we image the cervix, we want to try and make it as straight an angle as possible to the uterus. And we measure from the internal to the external os where the anterior and the posterior walls meet. And the literature tells us that if that cervix is less than 25 millimetres in the second or third trimester, we should perform a transvaginal scan. As I said, the cervix must be symmetric. So the width of the anterior wall should measure the same as the posterior wall. But if you press too hard on that uterus, it is going to elongate the cervix, and also the echogenicity might change. If we're doing a transabdominal scan, that can be difficult, particularly in late pregnancy, and it's not a very accurate method. It's affected by the amount of urine in the bladder, contractions, the fetal head position and the shadowing that causes, and also probe pressure and the size of the woman. Transabdominally, if the bladder is over full, it can elongate this cervix, and as you can see here, this cervix is 75 millimetres long, which is very long. Also, if we look at the anterior wall and the posterior wall of this cervix, see how thin the anterior wall is compared with the posterior. And that is because there is too much urine in the bladder, which has stretched it right out. We need to get that lady to empty her bladder a bit. In Australia, we might say to the lady, go to the toilet and count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3. It's not very reliable. You are better off giving them a little cup and asking them to let out 1 cupful or 2 cupfuls, etc. If the bladder was totally empty, again, we can't accurately measure that cervix with the transabdominal scan. Transvaginally, it is much more reliable. We need to optimize the image, make it bigger. Do not put too much pressure on it. And if the uterus is not straight, use the trace mode, and that will give you a much more accurate length. Again, if in this instance, if the bladder is not completely empty, it could hide any funneling of the cervix. As I mentioned before, this is the difference between going straight and the trace mode. And you can see here this anterior and posterior wall, and we call that the cucumber as to where to find the internal and the external os. Also, when we're measuring the distance of the placenta to the os, we don't just do a straight line, we are meant to do a trace along the myometrium. When we're looking at the placental edge to the cervix, again, it is much more accurate to do this with the transvaginal probe. And we should also put colour on it to check for any vasa previa. We always have a look at if there's a low-lying placenta in the second trimester, we get the lady back at about 32 to 34 weeks to reassess it to see if it has stretched out of the way, once that lower uterine segment has been developed. So we perform a transvaginal if the placenta is less than 20 millimetres from the cervix on transabdominal, or if vessels appear to be crossing the cervix. Again, the rules are to optimise the image so that we can see the internal os clearly. Use the colour, and again, if that placenta is out of the way, or less than 20 millimetres, we perform a transvaginal scan. So here's the internal os is actually here, not up here. And here's the edge of the placenta there. It's much clearer with the transvaginal. Again, if we've got the placenta covering the os, we need to measure how much it's covering it by. When there is a contraction in the way, don't go mistaking that for uterine, for the placental edge. So you can see here the echogenicity of the contraction is different to the placenta. So here's a contraction going on here in between the placental edge and the cervix. And again here. For placenta previa, there's an increased incidence in those women that have had multiple babies or previous caesarean sections, and that scarring in the lower uterine segment stops the stretching and so can't go pulling that placenta up out of the way. And maternal death from thrombosis from the antepartum and postpartum is caused from that placenta previa. Some countries use a grading system, others just do a measurement. So for those using a grading, the low is less than 20 millimetres away. If it's marginal or abuts it, as in here, or if it's partially covering it or totally covering it. The important thing here is to make sure we do a complete survey scan. Don't just put the transducer on and say it's an anti-inter. You need to scan from side to side. So with the vasa previa, bleeding from those vessels, there can be perinatal death in more than 50% of cases. And of the other 50% that survive, a good percentage of those could be brain damaged. And this can be avoided by doing a scan and checking for vasa previa. We did a study on this to look at the difference between the transabdominal and the transvaginal measurements. We measured the cervical length, internal to external, and also the leading placental edge to the internal os. And that was to assess what women needed to be defined for a transvaginal scan. We then looked at the inter and intra observer variation. So we looked at 400 consecutive patients from 13 weeks to term, and they've been referred for cervical assessment or a morphology scan or fetal growth and well-being. And we did a TA and a TV. Then we plotted the difference in millimetres, so we subtracted the transvaginal measurement from the transabdominal measurement and plotted them on a graph. So this was the difference in the cervical measurements. So if we look at 0 as being the optimum, you can see there was a huge difference between the TA and the TV. So the differences ranged from minus 20 millimetres to plus 34. That's a difference of 54 millimetres between those two measurements. The transabdominal method underestimated cervical length by about 2.5 millimetres. And the TA measurements detected only 1 of 17 cervixes less than 25 millimetres. This is the same cervix at 31 weeks. Transabdominal, 37 millimetres. Translabial, about 32. Transvaginal, about 20. Now in retrospect, this one has probably been over-measured, and this one hasn't been optimised. With a short cervix, transabdominal, 16 millimetres, and they'll just say, let's watch that. Don't go lifting anything heavy. Transvaginal, less than 7 millimetres. This woman was sent for bed rest. So this is possibly an overfull bladder. The image hasn't been optimised with depth, focus and gain. Looking at the placental edge to the cervical os, it was the same procedure as what we used before. And of those 400, there was about 200 odd that was in view of the transvaginal scan. Again, there was a big difference, ranging from minus 50 to plus 62 millimetres. A mean difference of almost 12 millimetres. So if we assume that the transvaginal is the gold standard, the transabdominal accurately predicted the leading edge of the placenta was within 25 millimetres in only 27% of cases. The intra and inter observer wasn't too bad for the intra observer. We were using a final year student for the inter observer, and so the difference was a bit wide. This is the same pregnancy, posterior placenta. On the transabdominal, oh, it's about 61 millimetres away. Move the head a bit, put the colour on, soon as we did the transvaginal, it's only 10 millimetres away. So we've gone from being okay to now being watched. This is another one. 38 millimetres, 22 millimetres. And again, luckily all of these were normal as far as distance away, but you can see how much clearer it is with the transvaginal. On this transabdominal, again, all within roughly normal range. This one, however, we're saying that the placental edge is 26 millimetres away. But look at this image. It hasn't been optimised. It's actually only 10 millimetres away. And when we put the colour on, we can see a cord insertion quite close to the edge. Again, this is the same one. Shadow over the cervix here with the TA and clearly seen with the transvaginal. Again, important to optimise the image. Here we're saying that it's 33 millimetres away, and when that image is optimised, it's about 15 millimetres away. Here's a large contraction here, and after the woman had emptied her bladder, contraction had gone. So the transabdominal measurement of the cervix and placental edge does not reflect the TV estimates. Both of those measurements are very important markers for pregnancy outcome and management. So the TA method is insufficient in clinical management. When we're measuring the placenta to cervix, it's much more reproducible with an anterior placenta, and the transabdominal has got a low sensitivity for detecting the low-lying placenta. The mean time required for that extension is probably about 5 minutes. With a cervical length, again the TA measurement was not reproducible, particularly in the third trimester, and that could have been due to bladder volume, maternal size, and shadowing over the os. The transabdominal measurements do not reflect the TV assessment accurately, particularly if the cervix is short, and that's what we're looking for. So at the 24 to 34 weeks, we found that the transabdominal only detected 10% of affected pregnancies. That is not good enough. So the recommendations to assist in achieving the best clinical outcomes was standardisation of scanning and measuring protocols for both the cervix and placental edge to help reduce those errors, and the addition of the transvaginal scan at all second trimester ultrasounds to assess the cervix and placental edge, and the addition of colour Doppler imaging of the cervix at every obstetric scan. Now this is what we do in quite a lot of practices in fetal medicine in Australia now. And I would like to invite all of you to come down to Melbourne in Australia in September for the World Federation meeting. There's going to be special rates for Vietnamese society. You just have to look on the website. And it's going to be a very exciting 4-day congress. There's going to be 8 streams, lots of international speakers, and you'll be very well received, so please come. Thank you very much.